Welcome, everybody. My name is Larry Hoffheimer, and I am the founder and chairman of the Macular Degeneration Association. I'll give you a little background on how we started and what we do. First of all, we are a very active supporter of patient education on macular degeneration as well as other related eye diseases. We have a very large following from all over the country, including places around the world. These programs you can find on our website, macularhope.org, and I hope you will tune in. We will be doing them for the rest of 2021, and we welcome you to participate. I do want to thank Regeneron and Novartis and Notovision for their support for our virtual programs. Heretofore, before the pandemic, we were doing these programs around the country in venues, generally in hotels, and we had a traveling team of presenters. We plan to pick up on that again probably in 2022. But this year we'll continue to do the virtual programs. So all that being said, my interest in macular degeneration really stemmed from my experience with my mother, who more than 20 years ago was diagnosed with wet macular degeneration and lost her entire central vision. There were no treatments at the time that were really effective, and that really diminished her quality of life. So I became very interested in this field, and that's why I started this organization. Interestingly enough, I guess you could call it interesting, about 2.5 years ago, I ended up with wet macular degeneration, and I received the eye injections and still do. My sister has macular degeneration in both of her eyes and receives eye injections. So the genetic component is very real. So all that being said, I'd like to talk about our subject today and introduce our speakers. Dry eye and ocular surface disease is what we're going to talk about today. We have a very, very well qualified and interesting speaker. She's Dr. Louise Sclafani, who is a 1989 alumnus of the Illinois College of Optometry and began her career at the University of Chicago in 1993. She was an associate professor of surgery and director of optometric services until 2017. Her main interests include contact lenses, corneal disease, dry eye, and macular and ocular aesthetics and corneal surgery. She will apply her many years of experience to challenging hospital-based care to her new role as Vice President of Professional Affairs at Synergy Eyes, training young doctors and providing quality services to her patients will always be her passion. I could go on and describe the many achievements and rewards she's received, but you will see those on the schedule as we move forward. She's a hockey mom, enjoys traveling, wine tasting, triathlons, and paddleboarding. Anyway, it's my pleasure to introduce to you Louise Sclafani. Dr. Sclafani.
Larry, that was very kind of you to invite me to be here today. So I know that things have changed quite a bit for us and the way we have to present. And I think that we've kind of gotten used to this pattern of doing things on Zoom meetings. I do miss being in person with my colleagues and my friends, and our population of people who are just interested in learning about these. So, it's interesting because I was invited to speak at this, and I think you saw one of my colleagues a few weeks ago, Dr. Pamela Lowe, who we're twins. Everybody calls us twins because we're both from Chicago. We kind of speak the same. We went to school together. Her maiden name is Sclevanites, and I'm Sclafani, so we're kind of like twins that way. But I know that one of the questions that she got was about dry eye, and there's a difference between dry macular degeneration, which I know many of you are very versed in, because I'm sure you've had a lot of discussion with other speakers about this. And we see it on the retina. And by the way, my husband works for a company called Aptos, where we see images like this. And so many of you might have had one of these done with your doctor, where we could actually look at macular degeneration. And of course, this is the way our vision potentially can end up if we don't get treatment for macular degeneration, that distortion, as well as that loss of central vision. But just because one has macular degeneration doesn't mean that other comorbidities can't exist, such as dry eye. And so today our conversation is going to be about dry eye disease. And it is a disease. It's not just a state of being. It's a disease that has a lot of different sequelae to it. We'll talk about that. And you may see what we see on the left, a red, irritated eye when we talk about dry eye. But for us, we look at a patient who just looks very uncomfortable, as we see on the right-hand side, and it isn't something that you should expect to have be just part of you. Dry eye is something that can be treated, and we're going to discuss that today. So dry eye disease has, evolved over the years. It used to be just something where we would say to patients, oh, just put some drops in your eyes, everything will be fine. And in 1995, the National Eye Institutes of Health had a workshop, and they gave the definition of dry eye as, tear deficiency, or where you don't have enough tears, or evaporation on the ocular surface. And that was what the definition was. In 1998, they added the fact that it has an immune-mediated inflammation effect. And that's important because if we know what the cause of the disease is, then we would treat it differently. So it's not just lack of tears, and it's not just evaporation of tears. It's also an inflammatory cycle that occurs on the front surface of the eye. And in 2017, they even added more to that definition. And it talks about not just what I just mentioned, but it also talks about a lack of homeostasis of the ocular tear film. And we all know that our bodies try to take care of themselves. They try to maintain this nature of well-being. And that's what we mean by homeostasis. And so, it tries to make up for parts of the tears that are missing, or where it's missing on the front surface. And that was added to that definition. And so that has to do with the tear quality, meaning how much saline is in it. That's hyperosmolarity. And then it also has to do with the brain and how the brain perceives what's going on the front surface, so that it can auto-regulate the rest of the body. So as you can see, there's been a lot of discussion on dry eye throughout the years. There's been these panels, there's been these workshops, there's been the top brains attending these meetings so that we could, address the situation and help find treatments that's better for our patients. So what do you see as dry eye? So let's talk about the symptoms of dry eye. And the reason why I'm going to mention these things is because you need to express them to your doctor, because they might not see it in the exam room. And the doctors also need to elicit some of these conversations. So we might ask you these questions, and it might be via a communication, just verbal communication, or it might be a handout. They may give you a sheet of paper with a questionnaire, and there's several different versions of these dry eye questionnaires. One of them is called the OSDI, or Ocular Surface Disease Index, and we qualitate how much you're symptomatic, and then we look at it in the future to see if we've resolved some of those symptoms. So some of the symptoms you might feel are dry eye sensation. Okay, but what does that mean? That might be like a foreign body sensation. Patients come in and say, I feel there's something in my eye. You got to get it out of my eye. And it's really not that there's something in there. It's just that the tears they're not good quality. Itchy or irritated eyes. So this irritation is very common, but itchiness is also a sign of dry eye. We always think itchy is allergy, and it can be, because it's a number one hallmark symptom of allergy is itchy, but it could also just mean dry eye. Injection, which means redness, like you see on the white part of the eye. The white part, the sclera is the white part, but it's not that the sclera the white part is inflamed, there's a tissue over it, and it's a clear tissue. It is called a conjunctiva, and that goes over the white part of the eye, and that can get inflamed or red. You've heard of the disease conjunctivitis or pink eye. It's not that, because those are viral infectious. This is just injected conjunctival tissue. Your eyes could look just tired, they just don't look bright like they should. The lids can be inflamed. They could have some crusting on them. And now this is an interesting symptom, excessive tearing. So that's because your body is, again, trying to remain homeostatic. And so sometimes your certain types of tears will overwork. And so excessive tearing is a big sign of dry eye. Blurred vision or glare, that might go away after you put some drops in your eyes or with rubbing your eyes, or is just not there all the time. It comes and goes. Maybe blinking helps resolve it, but it kind of comes and goes. But it does debilitate or reduce your vision. If you're a contact lens wearer, you might have shorter wearing time on your lenses, or you just can't wear them. But the main thing is, a lot of times patients say it's, oh, it is, I get dry at the end of the day, and they accept that. They think that's the new normal because they've lived with it so long, and you really shouldn't live with it. So these are some of the other factors that influence systemic diseases that affect dry eye. People, as we mature, especially women, our hormones will change, and that might cause more dry eye symptoms. People who have autoimmune disease, like rheumatoid arthritis or thyroid or lupus, they may have more likely to have dry eye. Then we also have like just eyelid issues, people who have deformed eyelids or who don't have really tight lids, and they might have some mechanical disturbances on their lids. Patients who've had some excessive cosmetic surgery, that could cause it because they just can't blink properly. Or and there's environmental issues that can have an effect too, such as temperature or humidity or just the air moving around. And we always tell patients, make sure you don't have direct air coming on you like a fan or an air conditioner, because that will definitely add to it. And then just some of the activities that we typically do, and some of those, well, I'll talk about that in a moment. But one of the other things is some medications. There are a lot of medications that can cause dry eye, and so when you're reading the side effects of your medications, look to see those. If they say may cause blurred vision, it's probably because it might be causing reduced teardrops. And there's a lot of medications that have to do with that. But one of the other things is we're going to talk about the tear film and how stable we could make that. So the tear film is not just one type of tear. So let's talk about it because it goes into great detail. One of the interesting things in the news was an artist by the name of Rosalind Fisher, who looked at tears from different types of people and experiencing different types of emotional things in their life. And she analyzed them and she put them under a microscope. And it's really cool because you could see that there's different parts, different qualities of or images of these tears. The tears of grief, or someone who is crying, has a different look to it than somebody who has who's tearing because they've been peeling an onion. I mean, these are beautiful images, but they do show that the tear is very complex. There's over 100 types of these tears, and some of them, and the reasons why we have them is because they're either responses to chemicals and the proteins that are in these tears, because a big part of the tear is a protein mix, make it look differently. And so some of them are there's some other things that look like emotional, some that are more reflex. And again, onion tears are reflex, whereas laughing or tears of grief, those are more of an emotional based tear. And the other thing is there's a different crying pattern for men versus women. And so typically in a month, a woman will cry for about up to 4 to 5 times. Of course, there are different issues in their life that might make them cry more, whereas men are more likely to cry less than 1 time a month and for less periods of time. Women cry for at least 4 minutes and men typically cry maybe 30 seconds. So obviously that'll be affected by emotions, but that's kind of a typical thing. Another interesting thing is that when men's testosterone levels will go up in response to a woman's tearing. So not the visual, but the actual parts of their tears. So it's kind of an interesting side note. But scientifically, or what we see on the tear layer, there are 3 different layers to them. The most external surface, the outside surface, is the lipid layer. And these are produced by the Meibomian glands. And we're going to talk about them a lot. But the Meibomian glands are these glands here that are right next to the eyelashes. And you can see these lines coming down. And these are really important to secrete these oils because it prevents the evaporation of all the tears that are underneath it. And it's very small, but it's probably the most important surface as far as making sure that we don't have dryness on the front surface. Then we have this large layer of aqueous tears, and that's the lacrimal gland produces those. And that lacrimal gland rests here on the top part of the temporal part of the lid. And then there's also some glands along the lid called Krause and Wolfring that also create those. And this is, as you can see, it's a very large layer, and this produces the necessary nutrition. It's got those proteins that we saw in that other image, and enzymes and oxygen carried through it. So it's very important to have a good aqueous layer. And then we have the mucin layer, and that's the one that's closest to the eyeball. And it's produced by goblet cells. So these goblet cells are found on the lid, inside lid, and also on the conjunctiva. And so these provide the foundation and regulates tension so that the tears can stay on the eye and that they can spread out evenly. And the mucin and the aqueous do get mixed up a little bit. We used to think they were totally separate layers, but they're not. They do mix a little bit. So it's important to have all of these intact. And the reason why is because we're protecting those delicate cells that are on the corneal. The corneal tissue is that clear tissue over the iris, the colored part of your eye, remember? So we have to protect the cornea because if the cornea is not happy, we're not happy. It doesn't feel good and we don't see well. And you could think of those cells like goldfish. The epithelial cell is like a goldfish, and it needs all of these things working. It needs all of these things working together, like oxygen. It needs good nutrition, such as glucose. It needs the pH to be right. It needs to have hydration. It needs to get garbage out of the eye. All of these things need to be working well in order for us to see and feel well. And as I mentioned before, there is this neuronal feedback that happens. The brain senses things that aren't right on the eyes, on the ocular surface, and it kind of kicks in and it lets the lacrimal gland know, hey, you got to start pumping out a little bit more tears. Otherwise, this eye's not going to be happy. And so it does that. And so there is this pathogenesis of this impulse loop that is also part of the system. And blinking is really, really important. So, we blink about, 10,000 times a day. I mean, we do a lot of blinking, and there's things that interrupt our blink system. And when we blink, we are protecting our ocular surface. And there's something called the tear breakup time. The tear breakup time means when this top image here is where the tear surface is really nice. And then you could see here in all these dark spots that represents the tear breaking up and not covering the surface as well. And that's when it starts to hurt or when our vision starts to blur. So we blink our eyes, and then if we say the breakup starts happening at about 4 seconds, the patient may not necessarily blink again, and it's not a good covered surface. And so this is a disease state where we have all this happening. And so unless they blink again, or unless we can improve this or reduce this evaporation rate, we're going to have a problem. And that problem is this. This is the staining that occurs on the cornea. And I'm going to talk about this in a little bit again. But this staining, I want you to remember that image. It's damage to the corneal tissue. And then it keeps repeating itself. So part of blinking is lid function. The lids have to work well and they have to be in the right position. So the lid's function is to protect the eyeball and is also to distribute and drain the tears. So what it blinks and then all the tears get distributed properly. Eventually there's these little holes called puncta in here where the tears and the garbage will drain through, and that has to be normal too. In the normal eye, you're going to see the top lid covers about 1/6 of that cornea, and the lower lid will reach right about the bottom. Now, everybody has a little bit different look to them, but this is the ideal look to the lid position. Unlike this patient who probably has some thyroid eye disease, where you can see that her lids on the top and the bottom are bigger than the cornea, and so she doesn't have as much protection. And so that's not ideal. And when we blink, you could see here, this is the natural movement of the blink. The goal is for the top lid to touch the bottom lid, and you can, and to have even amounts of time between it. You could see that she has a little bit of fluttering. You could see that sometimes she doesn't go meet the bottom lid. This is a nice movement. This is evaluating a contact lens on this patient, but you could see that she does consistently blink, and you could see that she touches the lower lid all the time. As opposed to this eye, where you could see when they blink, the top lid doesn't touch the bottom lid. And you see all that bright light shining. This is a drop called Fluorescein, which your doctor will put in the eye. And all that area on the bottom, you could see the tears breaking up. That's that black part of the lid. The tear breakup is the dark. But I just want to show you this again. But you could see that the white, the bright part, that bright part represents cells that are dying. And so that's what we call like scratching or dryness. Computer vision syndrome is very common, especially during COVID. And, it used to be the person in the middle was the only one using digital devices, but now we know that our younger kids and our older population are all using computers because we want to connect with our families. We want to look at things on Zoom, and we're just becoming more part of our lifestyle. The problem is with computers, we cut our blink rate quite a bit. So we have to really conscientiously make sure that we are stopping and blinking. There's something called the 20-20-20 rule. And what that means is that when you're working on your computer, every 20 minutes, you should take a break. You should look at about 20 feet away, and you should consciously blink for about 20 seconds doing that. I also add standing up, just trying to get your posture back in normal. So it's not normal for humans to keep staring at a computer for 5-6 hours a day. So we need to kind of break that cycle and make sure we give our eyes good breaks. Then there are also patients who wear contact lenses, and sometimes and many of you may have been wearing contact lenses from the early years and might be new wearers today. But there are rigid contact lenses that patients might have been wearing since the 70s and still are wearing. And based on the way they take their lenses out, they may end up with this ptosis. Ptosis means that the lid is riding lower than it's supposed to. You can see on the left hand, well, our right hand side, but that's the patient's left eye. That lid is lower. And that's typically because the patient takes out the lens like this, and they put that pressure on the lid, and that really just relaxes the muscle. And there's other things that people might be doing that like makeup insertion and removal might also do that kind of movement. This is how you should take out the lens. Okay. Using that so you're not putting pressure, or a device like this. So some of you may be wearing rigid lenses, or some of you may be wearing soft lenses, or some of you might be wearing scleral lenses, and we use these devices for that. And this is a lovely patient of mine who I've been seeing for over 30 years. And she did develop this ptosis. You could see here her lids were riding low, and this is her contact lens on the eye. And this is after she had lid surgery to elevate her lids so that she would look brighter, and that she wasn't losing any visual field because her lids were in a better position, and her contact lenses fit better now. Some of you might have seen this ad for Upneeq. Upneeq is a new medication that is given to patients who have temporary ptosis, and it's for acquired blepharoptosis or low-lying lids. You do need to see your doctor for this to have it prescribed. It's brand new. It's only been out for a couple of months now. It is an alpha adrenergic, so you have to be careful with this. Patients who have a certain type of glaucoma should not use it. Patients who have high blood pressure or cardiovascular disease need to talk to their internist about it, especially if they're taking a beta blocker or a MOA. So, but we have been getting nice success with this drop for patients. So what are the tests that your doctor might do on you to determine if you have dry eye? And then if you do, how do we treat it? So this is called a slit lamp, and this is just a big microscope. And I know many of you have been behind this for different types of examinations. And what we do is we put drops in our patient's eyes. And there's a certain drop called sodium fluorescein. It's like a green dot. We also put some lysomin green or some rose bengal. There's different dyes that we put in the eye. But when we put the drop in, first of all, I mentioned before, I showed you how the patient blinks their eye and keeps it open as long as they can. And we count the number of seconds before we start seeing these dark marks. Those dark marks represent tear evaporation. represents tear evaporation. And so that's what this is. The stain, we could also put the stain on the conjunctival tissue, and you could see that there it's picking up stain, and we don't like that. That means that there's a area where the cells are not healthy. And then the worst is if we have this drying on the front surface of the eye. So I always talk to my patients about this and I say, oh, well, you have some superficial punctate keratitis. And they're like, oh God, what does that mean? Well, basically what that means is that the cornea is like skin and it has lots of different layers. And the top surface of that skin has gotten dry and kind of flaked off. So I always like scratch on my hand and I show them, I say, see how this is all like kind of dry on my hand? Well, that's what's going on your eye. So that's what we want to treat, because you will feel that, it will hurt, and it will also blur your vision if it's in the over the pupil. So some other tests that your doctor might do is called tear osmolarity testing, and they will use it. There's like a little instrument here. It doesn't hurt or anything, and it just takes a sample of your tears, and it will measure the osmolarity or the salt content inside the eye. And tears is, as I mentioned, it has liquid and it has all these other components, these proteins, these enzymes, these salts, all this stuff inside of those tears, and it will take a measurement of those. And so some people have high osmolarity, and so that's not healthy. If the number is above 300, or if there's a big difference between the two eyes, we get concerned. So that's the type of tears. But then we could also measure tear quantity. And this is called a Schirmer test. And we put these little pieces of paper in the cul-de-sac here. And yes, this is a dog who's having this test done, because dogs, there's especially certain breeds, are prone to get dry eye too, and they just don't produce enough tears. But in our practice, we have humans doing this. And we typically will put a little anesthetic in the eye, because we don't want to measure reflex tears. We want, because everybody will tear a lot if they're feeling this piece of paper. We want to know what your baseline tears are. So that little blue line reflects how far the tears are. So that talks about quantity. And remember, I was mentioning before that lacrimal gland that's up here in the lid. That's that would tell us if the lacrimal gland's not working properly or not making enough tears. Now, the other thing your doctor might do is look at the Meibomian glands, and those are those glands along the lid margin. And now they're looking at the lower lid here. And they might take a little pen light and pull the lid down and see these nice lines. Those are nice, normal Meibomian glands, and they're secreting what their oil that they're supposed to, and they're nice, and they have lots of nice lines to them. Whereas opposed to this one on the left-hand side, where they're incipiated or plugged, you can see they're not narrow. They're all kind of like congested. They're all kind of stuck together. Nothing's coming out. Everything's getting blocked inside there. And then some of them might be blunted or lost. And people do lose their Meibomian glands if they're unhealthy. There's about 30 on each lid, and you really only need 6 to 10 to survive or to have good tears. But you could see that this patient's lost a lot. So if you don't have good Meibomian glands, those tears are going to evaporate. And this is a fancier piece of equipment called Lipiflow, and basically it's a imaging of those Meibomian glands a little bit differently, and where we can actually sit there and count those. So your doctor might want to do this test on you as well. Now, the whole reason why we do this is because we want to look at what's coming out of the Meibomian glands. And so there's different ways of looking to see what's coming out of the Meibomian gland. What we want is a nice oily tear layer like this. You could see when so the way we test this is we either push with, we can either push with a cotton swab, or we can use these little things to squeeze the lids, or we could put this blunt object between the eye and another instrument. You could see as we squeeze it, all that white stuff that's coming out. That white stuff that's coming out is not a good oily layer. We want the oily layer to be more like olive oil, like we see on that top right image. But on the bottom right image, we could see that it's kind of like Crisco, and that's not a good oily layer. So that's why the doctor will either do that to test your Meibomian glands, or do it as a treatment. They will squeeze these glands to help get rid of all that icky kind of Crisco oil tissue. And the reason why we do that is because if you don't have good oils, you can end up with a disease called blepharitis. And there's different kinds of blepharitis. There's anterior, meaning the front of the eye, or posterior, meaning the back of the eye. So on the front surface of the eye, when we look at the glands, we might see these scaly, scurfy kind of things. And your doctor might say, oh, it looks like you have dandruff of your eyelashes. It's similar to dandruff of your scalp, but we have it on the eyelashes. And you can see all these little scaly things. And believe me, they look a lot more damaging when we look at them under that microscope. We could also see the scaly of the lash. The whole lid, and it's very inflamed, and you could see the scaling on the skin itself. We could also see these little tiny telangiectatic blood vessels. People who have acne rosacea get these little tiny blood vessels on their lids or on the tip of their nose or on their cheeks, especially if they eat spicy food or drink too much red wine or other disease conditions. And so those are more anterior, and then posterior blepharitis, again, kind of showing you when we do that pushing and we kind of squeeze the stuff out, it looks kind of Crisco-y and cheesy, and we don't really like that. You could also see those scurfy lid margin there. And again, people who have this, not only is that a bad part of the disease, but they can also get something called Demodex. So we're going to talk about Demodex a little bit. Demodex is not a very tasteful discussion because it's kind of cringy, but we're going to talk about it because it is so common. So there's these little mites or these little bugs that feed on those oils that I was talking about, sometimes on hair, on hormones, but they love hair follicles. You can have them in your head, you can have them on your lashes, you can have them elsewhere. And people don't see them. You can't they don't come out and they pop out at you unless you're in your doctor's office and we're looking at them under the microscope. And they contribute to blepharitis, and they can cause chalazion or styes. When you get a stye on your lid, 65% of people who have styes also have Demodex. And when we break it apart, we can find those Demodex. They live a couple weeks, and everybody has Demodex. We're born with them, but they continue to increase as we mature. About 100% of people have them at the age of 70. And it's okay to have some, but it's when they get overpopulated. And the reason why they get overpopulated is because we don't take care of our lids properly. And so when the bioload gets too big, that's when we become symptomatic of them. So what the symptoms of Demodex include is those little scurfy dandruffs. They look like they're cylinders, and they kind of they hug onto the lashes like that. Sometimes your eyelashes can get misdirected and they're not going in the right direction. Sometimes we can have, again, I mentioned the Meibomian Gland dysfunction, or MGD, where those glands don't work right. We could get the lid margin being puffy or inflamed. We can have the conjunctival tissue being red, and on the worst case, it can affect the cornea, and we can have blood vessels growing onto the cornea, and that's a really bad thing. And what it is it's again, so many people have this, and what happens, and I'm going to show you this image here, this video, because it takes a little while. And again, the way we figure out if a patient has it, we see this cylindrical dandruff, and a doctor will go behind the microscope with their tweezers, and they'll start twirling the eyelash margin, or those lashes. And you're going to see that this is called the twirling test. And basically, we could see the cylindrical dandruff. And now what we're doing is he's twirling it around, because the thing is about these Demodex is they don't like light. And so they're going to hide when we get them behind the slit lamp. But if we twirl this around, they kind of come out. And so people who have Demodex and who have an overflow of them will get very itchy eyes in the middle of the night. And that's because in the middle of the night, that's when they like to come out. And as I mentioned before, this is very common. Most of us have this. It's just the amount that we have that is symptomatic that patient has. And it's not the reason why we have the symptoms, the itchiness, and you could see, I'm pointing to the little guy right here. You see him coming out of that eyelash right there, and you'll see it a little bit longer. He's coming out, and that is that little ugly bug that I was showing you previously in those pictures. And my husband's coming around because he wants to see what it looks like right now. But those little bugs come out, they come out on the eyelash, and we're gonna pull one out right here. And it's going to sit on the end of the forceps. There it is, on the tip of the forceps right here. And you're going to start seeing it wiggle on its own. And what we become, those symptoms that we get are more not from the active living bugs, but they're from the decaying bugs. When they die and decay, we have an immune response to those little critters' dead bodies. So I hope none of you are eating while we're doing this, but it is a nasty situation. And it's so common, and we want to make sure that we don't have that. So how do we take care of this? Let's talk about that. And there you go. You can see that little guy right there, kind of taking a little move. Ooh, he's growing. He's coming. He's stretching right now. Stretching, 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 and probably going to drop on someone's lap. So we got to get rid of that one. Okay. So that's got your attention. Now I know that if we've got your attention, we know that patients always ask, what can I do? How can I protect my eyes? So first thing is, be aware of different medications that dry our eyes out. Oral antihistamines, some diuretics, some, which means they're hypertensive drugs. Not that you should go off of them, but just be aware if you have them that you're going to be more symptomatic of dry eye. You can manage your own evaporation rate. What I mean by that is open your eyes as wide as you can. And when you're at home, see how long you can keep them open. And then if you can't keep them open long enough because your eyes start to irritate you, talk to your doctor about that. We don't want you keeping them open. It's just a diagnostic test. Be aware of the computer tasks. Again, cut back on your computer time or take blinks in between. Be aware of adverse environments like dry, windy places. But most important, we're going to talk about lid hygiene now. What can we do for lid hygiene? So doctor's going to tell you when they see those little heebie-jeebie Demodex or stuff like that, we're going to tell you what to do. There is so much out there about dry eye. There's a dry eye talk website that you can go to. There's so many different drops. It gets confusing. There's lid hygiene. There's contact lenses. There's some other things, and we're going to talk about all these things. And just one thing I want to bring up is there is actually a drop that helps your dog with dry eye. And one of the components of it actually reverses cataracts. This is available overseas. You can't get this in the United States. It's not FDA approved, but there are humans who fly this in for themselves and use it because they want to reduce cataracts. You can imagine it didn't get approved here in the US because our cataract surgeons want cataracts, right? It's a good way of taking care of you. Anyways, so treatment starts at home with good lid hygiene and warm, moist heat. Okay. So what that means is a warm washcloth, nothing on it, no soaps or anything. Warm, moist heat just from the tap water. You could do it in the shower or you can do it at your sink. Every day, this should be part of your routine. So you should hold that warm, moist, clean washcloth, use a clean one every day, hold it on there till it cools off, and then repeat it. So again, that's just hot tap water held on your lids, a little bit of pressure. You could use these Brooder masks. These Brooder masks are wonderful, especially if you do have dry eye disease. You put these in the microwave. You can get these over the counter or online. You put these on for about 15, 20 minutes. They feel great. It's a nice little spa treatment. There are some people who rather buying one of these or sitting behind the sink will make their own. They'll use a tea bag. They'll warm it up. They'll take out most of the the water, and then they'll put those on their lids. And I would recommend something that has a nice scent to it, like lavender or primrose, something like that. And then some people make these little with rice packs. They use a sock, they fill it up with rice, they sew it up. It's like just the toe part, and they'll put it in the microwave, and they'll use that because then they can get sustained heat. So those are different ways of doing warm, moist heat. Now, many of you have been told to use baby oil to wash your eyelids. No, 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 no. Never use baby shampoo. Baby shampoo is again, definitely not recommended. And if your doctor's telling you to use it, they need to refer to some of these journal articles, because we know that Johnson's baby shampoo can cause excessive drying. It causes burning, which is mild. We're not so worried about that, but it damages that lipid layer. That outside layer we've been talking about is not getting clean. So it is not as going to dry out. So we don't want to get rid of that. And it doesn't really affect bacterial colonization. So we are really shifted away from baby shampoo. There are products though that we do recommend for good hygiene. So if your doctor tells you, you know what, you got blepharitis, and I'm worried about you because you have dry eye symptoms that go along with it, then you may want to switch to something more, a different regimen or commercially available. This is Ocusoft. The Ocusoft family has some things for routine daily hygiene to stay on treatment for more advanced disease. And these are very effective against bacteria as well as against Demodex. And there's some other ones too. And you can get it for a baby. It's a little bit milder form for babies too. Then there's Sterilid, and this is a foam, and it has a little bit of tea tree oil in it and some other oils. And then, again, this is antimicrobial, and it can decrease the Demodex population as well. And it's a little foam that you use, and you can wash your lids with it. These are over the counter. And then there's hypochlorous acid, which has really gotten a new it's become very popular recently. Avanova was the first company to put out hypochlorous acid, and it's very effective against the Demodex and the nymph stage, which is a certain part of the life cycle. And surprisingly, it has the same activity as betadine. And you know, your surgeons will use betadine on the eye to kill a lot of bacteria. So it's very, very effective, but less toxic than betadine because that will sting. So this can be used every day. I love the Zenoptic. This is something we use in our practice all the time, and I use on my own eyes. And it's just a spray that you just spray on your lids and you keep it on there. You close your eyes, spray it, and it gives you good daily hygiene. And then there are some natural lid cleansers. Tea tree oil has been around for a while, and it comes from New Zealand. And it's actually the oil from the tea tree. And it's antimicrobial, anti-inflammatory, anti-protozoal, antiviral. It is toxic to the ocular surface, so you have to use very, very low concentrations. And tea tree oil, that's only recommended for the eye. And so Claridex is a preservative-free pads that you can get with some tea tree oil in it. And then there's Manuka Honey. I'm sorry, Manuka Honey is from New Zealand. And this is honey made from bees that pollinate from the Manuka trees. And it's an ancient treatment used for psoriasis, for rashes. It's an antiseptic, antimicrobial. It helps in wound healing, for diaper rash. When you get this, you want to make sure that it's medical grade. The honey is dissolved in some oils. And if your doctor says you got Demodex, they're going to recommend that you use this daily for 1 week and then 3 times a week until you can decrease that population of Demodex. And then there's coconut oil, which also has antibacterial, anti-candida, antioxidant, anti-inflammatory. And you put this on your lids for about, rub it in gently, keep it in for about 20 minutes, and then you wipe it off with a dry cloth. People use coconut oil all over. My mom uses coconut oil all over her skin. Her skin looks beautiful, but she keeps that on. But around the lids, you should take it off after about 20 minutes. And again, this is effective against Demodex, and it's also effective for your oily tear layers. So these are awesome natural cleansers you can get. Any of you who are wearing makeup, which is probably half of you out there, make sure that when you're using makeup that you respect the mucosal line, which means don't put any eyeliner along this part. Keep it on the outside of your eyelashes. You can see she's losing all her eyelashes because she's put so much on this area. Remember, those are where the Meibomian glands are. Protect that. Don't use those curlers, eyelash curlers. Tug off your lashes. You're going to lose them. Make sure you wash them every night. Now, I recommend using baby oil to take off my eye makeup. Baby oil, not baby shampoo. Baby oil, again, is very effective and inexpensive. And I would also recommend avoiding any makeup that has glitter in it, these little glitter powders, and those permanent eyelash extensions. Eyelash extensions are probably one of the worst things for your eyes. Eyelash extensions they use glue. The glue attracts potentially Demodex. I look at this patient with these fake eyelashes, and I don't know if that's Demodex or if it's the glue. So please stay away from those permanent eyelashes. If you want to put a pair on for the night and take them off at the end of the night, that's great, but don't put the permanent ones on. We see that there's other instruments that we can use to evaluate, again, the tears. Remember, we're looking at the Meibomian glands again here, but look at this. This makeup is building up and becoming part of this patient's underneath. It's getting trapped underneath the tissue and staining the tissue. So you have to wash off that makeup every night. Now, I talked to you about how we can take care of our eyelids, but your doctor may decide to do some eyelid scraping. And there's an instrument called the Blephx, and they will take this instrument, the ileal surface, a blunt instrument to do this as well, scrape it off. So that's an in-office procedure that your doctor might recommend. And then there's this other in-office procedure that maybe some of you have been using or been offered. It's called Lipiflow. And basically, instead of doing those hot compresses at night that we talked about, they use an instrument that is attached to the lids, and it adds warmth and it adds a little bit of pressure, and it helps release all of that blocked up oils in there. And it takes about 15 minutes, and it doesn't hurt, just a little pressure. And the effects last from 6 to 12 months, depending on the eye condition that you have. And it costs, this is the cost associated with it, and it's not covered. This is an out-of-pocket expense, but many people get a lot of relief from this. And there's a couple different versions of this instrument. And then finally, there's this intense pulse light therapy. And basically what happens here is there's a little bit of goo put around the eyelid, and then the light, this intense light is applied, and it melts the Meibomian gland secretions. So the oil is now oily, not Crisco-y. It decreases bacteria. It helps reduce Demodex. It reduces inflammation. So people who have Acne Rosacea benefit. It also helps with people who have some pigmentation issues or sun damage. It also stimulates collagen production. So make sure, so it's a cosmetic procedure too, to make the eyes look a little plumper. And you do about 3 to 5 treatments, about 3 to 5 weeks apart, and it costs about $350 per, and again, this is out of pocket, but something that optometrists are doing quite rapidly recently. Now, I know we talked about not wearing those eyelash extensions. If you do desire to grow your eyelashes yourself, you can. Latisse is a great drop. You'll notice that if any of you have glaucoma and you are taking a prostaglandin such as Lumigan, that actually helps your eyelashes grow. And so as we saw, that was a side effect. Now we can prescribe it in the form of Latisse, and it's not put in the eye, it's actually put on the eyelash margin and will help increase growth. There's also an over-the-counter enhancer called Zoria, and that is made from OcuSoft. So I know a lot of people are looking for a longer eyelash. Just be careful what you're asking for, because sometimes there is a little overgrowth, maybe not as extensive as this, but it really is effective. So next we're going to talk about artificial tears, because a lot of you have been told by your doctor, go get some artificial tears. And I think it's important that there is a difference between those artificial tears. The goals of treatment with artificial tears is for an eye drop to those drops should stay on the eye for a long time and offer some protection, but not cause any blur for you. And they shouldn't cake on the lids, and they shouldn't have any preservatives in it that could be irritated. And they should give you the effect of making you feel good and see better. And artificial tears do this by a number of ways. One is they can increase the retention of the tears that are present by preventing evaporation. So they can have some oil to them, so they prevent the evaporation, or they can help the tears stick to the eye better, meaning improving the mucin layer. And overall, though, what happens when our tear layer is better? We get less inflammation, we have less redness, and then environment's just better. So for those of you who've been told that you have a lipid deficiency or you have an evaporative dry eye, things that have a base of castor or mineral oil, vitamin E, or Lipizime, these are things that will, help improve that lipid layer. So these are some of the drops that are very effective for that. Things that say sustain balance, soothe XP, MGD, it's Retain is a really good drop. It's made specifically for people who have Meibomian gland dysfunction. And then there's some spray on lipozymes, the tears again. Then for those who have an aqueous replacement issue, so those are people who have lacrimal gland deficiency, and maybe that's because they have Sjogren's syndrome, or they have other autoimmune issues that are not allowing the lacrimal gland to secrete properly, then we just need some more aqueous replacement. And these are some of the more common drops. The whole Refresh family is great because most of the Refresh don't have any preservatives in it, and they come in single servers, and those are really effective. So here's a whole list of other drops that you might want to use. And then for those who have mucin deficiency and those tears are not stable, these are some really good drops for those. I love the Blink family because Blink has something called hyaluronic acid in it. And hyaluronic acid is good for this mucin issue, but it also helps recovery. Like, so if you do have some damaged cells, it really helps them improve and get better. So I really, really like the Blink family. And there's two different ones listed here because Blink Tears is thinner, and then Blink Gel Tears, it's still a liquid, but it's much thicker. And so we use that one more at night because it might blur the vision a little bit. So you could see one is from mild to moderate and one is from moderate to severe. But it works really great, and it's really good when you blink because it's got the same stuff that synovial fluid has it. Think about our knees. You know, you might have been told your knees are rubbing and you might need a knee replacement. That's because you're missing some synovial fluid. And this is the same kind of stuff that helps when two particles rub against each other. So it's like the lid touching the eyeball. And then people who have osmolarity imbalance, and as I mentioned, I showed you that doctor would have to test for that. These drops are good for it, but they're also good for other things too. And then if you do need overnight protection, because for example, this guy can't shut his eye all the way. So he has exposure, and that exposure is might be because of just the anatomy of his eye, or he might have some other nerve innervation issues. So we need a little bit thicker drop for that. And there's a lot of ointments. And when we put an ointment in, we pull the lower lid down, we put it on the pink part of our eye, and then we go to bed. And we tell our patients, it's going to be blurry. That's why we use it before we go to bed. So just our dreams are blurry. Now, some of you might be using, have heard of Lumify. It's an over-the-counter drop that came out about 1.5 or 2 years ago by Bausch & Lomb. And so one of the things that bothers us is when we got red eyes. And so we want to get rid of the red eye. So the most important thing is that when you have a red eye, it's because you have a disease going on most likely. And that disease is either Demodex or Meibomian Gland disease or blepharitis or dry eye disease. And so we need to treat the underlying disease, okay? And once we've done that, hopefully the redness will go away. But there's all these other factors. For example, I said it could be due to the environment. So use a humidifier. Okay, that's really important. Use supplements, as we just talked about, artificial tear supplements. Don't sleep with your makeup on. Take it all off at night. Consider an antihistamine if you have allergies. Don't use irritating ingredients. Stay away from cigarette smoke. It's really bad for our eyes. And protect your eyes from the sun. So you've been told probably for macular degeneration, we need to protect our eyes from the dangers of UV. Well, the UV also affects all of the tissue around the eye. But you should avoid red eye drops. So anything like that says gets the red out, like Visine and some of the other vasoconstrictors, what they do is they close off the arteries and the veins in the eye. So there's no blood flow. Well, that's not good to have that. And eventually what happens is blood's going to get stuck in there and it's no longer going to work. Our valves in our eyes aren't going to work. Lumify is a drop that actually just targets the veins. So the arteries can still flow, but the veins, while you're using this drop, are constricted. So we get less blood flow there. So this is a really good drop. I would recommend to use it maybe no more than a couple times a week. When you need to take a picture, look your best, go on a date or something like that, that's when you would use your Lumify. And it has something called bromonidine in it, which again it's another glaucoma agent, but a very low concentration of one of those glaucoma agents. So many of you who are on Alphagan for your glaucoma, you probably notice, hey, I got pretty white eyes. Well, this is a low concentration of it. And then if we, the other drops that we might consider are drops or medications that reduce inflammation and increase tear production. So these might be prescribed by your doctor. Some of you might be on these medications. Restasis has been around for at least 15 years at this point. It's cyclosporin. It is amazing. It works great, and people don't run out of its oomph, meaning it continues to work for them. It comes in a non-preserved form or a multi-dose that has a diminishing preservative, whatever works best for you. I prefer the non-preserved, and patients who do not do well or do not get their symptoms relieved by Restasis might be switched to Cequa, which is still cyclosporin, but at almost double the concentration. And then a new drug on the market, not new, it's been out for about 4 years, is Xiidra, and it works on a different, it's a totally different type of drop. So your doctor and you will discuss which would be the best for you. Another treatment might be punctal plugs. These are plugs. Remember, I told you you make tears, but they got to go somewhere at the end of the day. And so they go down these little drains, these little holes that are close to the nasal part of your eye. But sometimes we might want to prevent those from going down there. Maybe we want to keep the tears on the eye longer. So you could plug them up with these little plastic inserts. I personally prefer those that are temporary, because eventually, if you keep these in, the brain, that cycle, that neurosensory cycle, the brain's going to say, I don't need to make any more tears anymore. And so these don't have any much effect anymore. So there are some temporary ones or dissolvable ones. And when I say temporary, that means that the doctor can pull it out. But there's some dissolvable ones too that last about 60 days. And I like those. And you don't see them because they push them down a little bit deeper. And then there's specialty contact lenses. There are scleral contact lenses. These are hard contact lenses that go from here to here, and they create a tear reservoir to improve the surface quality and vision. And your doctor might prescribe those. Okay, I've got just a couple more slides to go over, and one of them is this. This is something you can all do right now. I want you all to just kind of take some really deep breaths and hold it in, and take that breath from your abdomen. Hold it in and hold it as long as you can, and then you're going to gently release it. Now, many of you might do yoga, or many of you might do meditation. We do breathing exercises when we're doing those activities, and those have been shown to increase tear production. So I want you to keep that in mind too. A natural way of increasing your own tears is just taking deep, relaxed breaths. And sometimes it might be you're doing it while you're working on your computer, or while you're working, or just if you're doing any meditation, you'll probably notice that you don't get dry eye during those times. And that's kind of how we figured it out. It also lowers your blood pressure, so it's all good there. We could also tickle our noses, and this is a device that came up by Allergan a couple years ago, and it's nasal stimulation. And this, you put those two little tips up your nose, and they vibrate, and boy, do you make a lot of tears. So this came out. It's effective. It's always sticking a pencil up my nose. Okay, it's effective too. A new device that came out is where you put the instrument on the outside. I don't have any images because it's brand new, and that might stimulate nasal production to make some more tears. So these are some other things that we use. And then finally, last thing I want to talk about is you are what you eat. So don't forget, you are what you eat. So I need to eat a skinny person personally so that I become that skinny person. But there are some nutritional things that we can do to help our dry eyes too. Mentioned before, there's been a lot of research. The DEW study came out a couple years ago, and this was a workshop put again by the best brains in dry eye from around the world came together and came up with a schedule of how we should treat eye disease. And under step one, we used to have all these other things under step one, and they modified the treatment plan where if we changed the dietary patterns, it used to be like under step 4, but they've moved it up the cycle, up the ladder, so that we start talking to patients about dietary issues first. So fatty acids, essential fatty acids, are very important in our whole health system. We know they help with cell membranes, they help reduce prostaglandins, which help with inflammation. And most important for us for this topic is they improve the lipid layer of our tears. Now, there's essential fatty acids are found in lots of different foods, and there's different kinds. There's omega-3, omega-6, omega-9. Our body makes omega-9, so we don't really need to add any additional there. And those are the ones that are a little bit higher fat in fat. Those are like peanuts and avocados and hazelnuts. So those are good to eat, but don't eat too much of those. The omega-6s are very good for us, and that includes pork and chicken and dairy and pine nuts and pumpkin seeds and some avocado oil. So those are good, but they can only be eaten in moderation. Omega-3s are the best thing for us and for our eyes. That's including like salmon and trout and fresh tuna, fish oil, flaxseed, Brussels sprouts and kale, parsley, mint, watercress, all those really nice, healthy omega-3s. And in our diets, we should have a ratio of 4-to-1, meaning omega-6s should be 4 times the omega-3s, okay? Unfortunately, the American diet is more like 15-to-1. So we're eating way too many omega-6s and we need to increase the omega-3s. So kind of keep that in mind. Raw nuts are another method of omega-3s, and raw nuts as opposed to dried nuts are better because they're time release. They'll help you throughout the day. In flaxseed oil, 1 tablespoon is about 1.5 grams, and as I was showing you before, we need about 12 grams of omega 6s to 3 grams of omega-3. So that's a good method. We found this out. There was a study published in 2005, and it looked at over 32,000 women, and it looked at the amount of omega-3s that they had in their natural diet, and they noticed that women who, and most of them got that omega-3 eating tuna, and if they ate more omega-3s, they could reduce their dry eye by 30%. Patients who didn't had a much higher level of dry eye. So that balance has to be good. And the reason why it works is because, again, it helps that lacrimal gland produce the right amount of tears. So these are some other dietary components we've seen: vitamin A, D, E, primrose, evening primrose, turmeric. I love turmeric, especially when I eat it in my chocolate, turmeric ginger. Green tea is good for your dry eye. And these are some of the other things that we have in our diet. Caffeine. We used to think that caffeine dried us out. Well, it doesn't. There was a study that gave patients not real coffee, but they gave them caffeine tablets, and they saw that those patients, compared to people who had the placebo, had a higher amount of tears in their eye. So we don't want to have too much caffeine, though. About 3 cups a day is about what's recommended. And for those of you who are at risk for glaucoma, there is an association between people who have glaucoma, family history of glaucoma, and caffeine. You want to make sure you're not overdoing that caffeine. So finally, my last slide here is, again, there are other sources where we can find help our tear layer, and those are something called complex phenols or flavonoids, and these are found in many foods, and they are very helpful in the treatment of dry eye. I've talked about Manuka honey on the eye, but Manuka honey in the mouth as well as helpful. Quercetin is something found in grape skins, and the polyphenols that we see in red wine and in green tea are really, really helpful. And some of you might love to indulge in red wine, as I do, and that's red wine has a lot of resveratrol in it. Resveratrol, we know, helps with inflammation in general. It helps suppress something called MMPs, and those are things that are bad on the front surface of the eye, and so it helps the cornea heal, and it helps reduce neovascularization, and that's blood vessel growth. So I think the resveratrol is very, very healthy. So in summary, there are lots of ways of treating the eye. You need to work with your doctor to figure out, prevention, of course, with keeping your eyelids nice and clean, tear supplementation when necessary, and making sure you're using the right kind. But it all starts with a clean environment, and that, I think, is key. If that doesn't work, your doctor might suggest specialty contact lenses, might suggest some steroids or some anti-inflammatory drugs, as we talked about, might suggest nasal stimulation, might cause some of these in-office procedures that can be helpful. Again, something good for you and your dog. Joking there, but in general, I would go for the glass of wine in the end. So I'm going to open it up again. When we're looking at you, we're looking at the back of the eye, we're looking at the front of the eye, we're trying to prescribe glasses and contacts. We do a lot of multitasking. It's the enemy of what we do, but we have to remember that those eyeballs that you have are attached to a big body, your human body, which can affect the eyeball, and with the front of the eye and the back of the eye all have different things that go along with it. So I want to thank you for letting me have this conversation with you today, and I will open it up to questions, I believe, right now, of which we have about 7. Okay. So first question is, I had my eyes examined and the doctor found that I had an allergic conjunctivitis and suggested Pataday. However, I have dry eye and she told me to use artificial tears. Didn't suggest one. What should I use? So Pataday is an over-the-counter allergy drop. It has 2 different components to it. It used to be had to be prescribed, but now you can get it over the counter. It is really an awesome drug that we use Pataday use once a day, Patanol use twice a day. It's very good for allergic conjunctivitis. And sometimes people, and as mentioned before, if you have, you may have dry eye as a side effect of an allergic conjunctivitis. So if you are just using lubricants in the eye, you can flush out the allergens, so that can help your allergies. But you have to pay attention to the season. There may be no flushing you could do. You may need to have one of these allergy drops. So I love Pataday if you truly have allergy eyes. And your doctor can tell that because when we flip the lids over, we get these little bumps called papillae. And your doctor may have seen these papillae and said, oh, this is definitely allergic component. Okay, so that's why the Pataday is prescribed. But remember, I told you one of the hallmarks of allergy is itchy eyes. Well, itchy eyes goes with allergy, it could go with dry eye, and it could go with Demodex. So we want to make sure that we've ruled out Demodex and we've ruled out dry eye. So there's nothing ever wrong with using lubricating drops in addition to an allergy drop. I would stick probably with the Refresh family because their doctor probably didn't specifically say you have an oil deficiency or a mucin deficiency. So probably using some of the Refresh will help rinse out those allergies and will also help with the lubricants. So yeah, that's a great question because a lot of times it's very hard to distinguish between the two, but often they also coexist. So keep that in mind. Okay, I am a diabetic and get blurry vision at times. My blood sugar is under control. Can this be dry eye? Without a doubt, this could be dry eye. So first of all, obviously, if you're watching your sugars and you're not having spikes, just so you know, like when we see eyeglass prescription changes or refractive changes because of sugar levels, it's typically a high sugar level, like above 300. Okay. And those will come and go as your sugars come and go. So people will say, sometimes I could read up close and sometimes I can't, or sometimes I can see far away and sometimes I can't. It just comes and goes. So obviously you have to work with your doctor to make sure your sugars are well controlled. Then there are, if you have chronic, excuse me, sugar levels that are high, you can obviously get diabetic retinopathy, which is a whole other issue which needs to be treated. Or you can also get early cataracts, which won't come and go. Those will, continue to get worse in early cataract surgery. But you can also have dry eye. And so if it's blurry, if it changes throughout the day, if blinking helps, most likely it's dry eye. Diabetics have a high chance of having dry eye. So yes, it could definitely be this. My eyes are, I'm just going to take a little sip here. By the way, what goes in the mouth gets to the eye too. So if you have a dry throat, that can dry your eyes out. So drinking a lot of water while you're working on your computer is really helpful. Okay, my eyes are red and have streaks under my lids. What should I be using? Let's see, my eyes are red and have streaks under my eyelids. So I'm trying to fix, so the streaks are on the eyes and they're also on the lids. So if you have those little telangiectatic blood vessels that I showed in that one picture, these are little like spider veins that are along the eyelash margin, you may have acne rosacea. And acne rosacea is an inflammatory condition, which certain things set it off, like spicy food or red wine or certain things like that, and those will get even redder. So good lid hygiene, again, is very helpful for that. Also, some patients who have these red lines on their eyelids have a benefit from oral antibiotic called doxycycline. And it's not because it's treating the bugs. It's not an antibiotic in this method. They're using it to kind of suppress the immune system. So talk to your doctor about that. They might want to prescribe a low dose of doxycycline for those little blood vessels or those red streaks under the lids. is there a special doctor I should be seeing for this condition? I'm assuming dry eye disease. So yes, I mean, there are most most optometrists and most ophthalmologists are equipped to treat this. But I'm going to tell you, if you go to your retina specialist because you have macular degeneration, they're not going to be looking at your lids. So you need to see somebody who specializes in more of the front portion of the eye. So an optometrist and an ophthalmologist, both of them can look at that. In most, and there are some, if your doctor says to you, just go get some drops over the counter, they might not be really looking at the dry eye as a disease. They're just kind of supplementing things. So if you have a severe dry eye, there are certain optometrists who will really have all the tools in their practice to do things. You don't need all the tools to be a dry eye specialist, but they will kind of dissociate the different types of dry eye. So, just ask your doctor, or when you call to make the appointment, listen, I know I really feel I have a dry eye disease. Does your doctor specialize that? Is this something that they like to take care of? They may say yes or no. If they say no, they might say refer you out, or they might say, hey, I'm not, but this other doctor in my practice really likes that, really will spend time with you. My eyes seem to itch at night. They seem to irritate. Okay, my eyes seem to itch at night. Does this mean I have those bugs you mentioned? It could. Yeah, it could. Again, I'm sorry to say that, but they do like to come out at night, and they maybe do become more symptomatic. It doesn't necessarily mean you have them. I'm going to repeat that. Everybody has Demodex. As I mentioned, you're born with it. But when we have an over surplus of it, then it most likely is going to you'll become symptomatic. And itching is one of the biggest symptoms, and at night even more. Now, if you're saying that they become itchy at night, like it's towards the end of the day and you're still in bright light, you're not sitting there sleeping, you're just you're in your home with your lights on and they're itching, it could also just be dry eye, because the longer we're awake, the more our eyes are open and we have more chance for our tears to evaporate, right? So we do become more symptomatic at the end of the day, and it doesn't have to be because of the Demodex. But if you're in a bed sleeping and your eyes are itching, it gets worse in the middle of the night, there's a high likelihood it is. When I use the lid scrubs, they seem to irritate them. Is there anything else that I can use? That's really good. So I would probably shift away from maybe the commercially available lid scrubs. First of all, try just warm water. Okay. But if that's not getting rid of the symptoms, then try, as I mentioned, the coconut oil. That might be a little bit more beneficial, or just using some of those sprays I mentioned. And you might be getting a little bit too aggressive with the lid scrubs, and maybe you shouldn't use them every day, maybe once a week. Again, ask your doctor, because when I first see like those lashes that have all those dandruff in there, we're going to be aggressive. We're going to treat it every day like that. But then we're going to slow it down, because once hopefully we'll get it under control, we'll get the majority of the schmutz off of the lashes, and then we're just going to be maintaining, so you don't need them every day. Why don't eye doctors perform the tests that you mentioned as part of an eye exam? So they do perform a lot of those tests. So every doctor should look at you behind that microscope. That slit lamp exam is essential and is part of a routine eye exam. And they do look at the eyelashes. And they do also look at, you're definitely having your lashes scanned, and they're probably using a small swab to look on the inside of your lids. But unless you have some symptoms, they might not get aggressive with using all the other tests. So meaning the meibomiography, personally, you don't need to use that. A lot of offices don't have that, so they can just use the light to look at it. So they might not have that sophisticated piece of equipment. Doesn't mean they can't treat dry eye. They just aren't looking at it that way. The dyes that I mentioned, every office has those dyes. So they might be using it and you're not even aware they're using it, because we put it in so quickly sometimes. Looking at tear evaporation, yes, that not typically you do have to use a dye for that, or some of the other tools you could look at it without putting a dye in. But most doctors are looking for doing a screening for dry eye, and then once they're prompted by the questions or by your symptoms, they'll do more of those tests, like the Schirmer test or the squeezing test and those kind of things. So my lids droop. I'm interested in the drop that you spoke about. Can you tell us more? So yes, so that Upneek is kind of new on the market. And for example, in my practice, we do in office. Well, first of all, we do screenings on patients, and we make sure that their blood pressure is well controlled. And we also then look at the structure of the eye to make sure that they don't have a certain type of, or they're not at risk for a certain type of glaucoma called narrow angle glaucoma. So we make sure their angles are open. And then we'll do an in-office test, and we'll put the drop in, maybe just what, well, first of all, we'll measure the distance between the top and the bottom lid, and we'll take a picture, and then we'll put a drop in, and then we'll wait 15 minutes, and then we'll look at them again, and we'll remeasure and take another picture. So it's effective for some patients and not for others, but I think almost everybody I've put it in, it's worked for them. And that drop is temporary, though. It only works when you use it, so it works for that day. I think they're recommending it only a couple times a week because of the potential for hypertensive or cardiovascular issues on those patients who are at risk. So if you do have any of those conditions, I would definitely talk to your doctor about it. And it's a form of it's an alpha adrenergic, and so your doctor has to trial it, and then your doctor has to order it because it's not available over the counter. You can't get it from a regular pharmacist at present because it is still new. It comes directly from the manufacturer. So yeah, talk to your doctor about it. Have them do a trial in office if you're a good candidate, and then once we know it works, then your doctor can call in the script for it. My eyes tear and sting. Is that dry eye? Yes, probably. Okay, so again, those are typical. So again, the reason why our eyes tear is because of this, and I don't think I explained this clearly. The reason why our eyes tear is this. The outside surface of the tears, again, that oily layer prevents evaporation. If it's evaporating quickly, our body says, oh gosh, things are going away. I got to start producing more. And the thing that our eyeball can make is the basal tears, or that watery, that aqueous, the lacrimal gland kicks in and goes, I'm going to double duty this. I'm going to make a lot more tears because my eyeball is saying it's evaporating too quickly. So that's why we make excessive tears, and they could spill all on the outside of our eye. So that's probably it. And then stinging is just, yeah, it's a response to air coming at this dry spot. Remember those little black spots I showed you? Those are dry spots, and it doesn't like that. It's a good question. This next one. Are highly myopic eyes more prone to dry eye disease because of the shape of the eyeball? That's a great question. So I'm going to say that highly myopic eyes might be more prone to dry eye disease because a lot of highly myopic eyes are wearing contact lenses. And so although contact lenses are not contraindicated for dry eye, they could make contact lenses uncomfortable unless you treat the dry eye too. So that would be one thing. And then the shape, I think they're alluding to the fact that myopic eyes are typically longer in axial length. Most of that growth is backwards. And so although it's not good for the overall eye health, it doesn't cause more dry eye. But if it is more protruding forward and the lid isn't covering it properly, then again, you're not going to get the protection, and you're not going to get the tears smoothing out the tear surface, the tear layer. And so in that respect, it would be. And so there are a lot of myopic eyes that might have more protrusion forward if that's the way the eye is growing. Yeah, well, I love this one. I use my computer a lot and notice that my eyes burn after a while. What can I do? Artificial tears, which one? So the first thing again is lifestyle changes. And that means that 20-20-20 rule. Every 20 minutes, look away from your computer, look at 20 feet, and for 20 seconds and blink. Do some conscious blinking, because when we work on our computer, we reduce our tear blinking by 50%. That's a lot. That's a lot of reduction in tear production, or in blinking. So I also recommend, if I'm going to, our jobs, sometimes we go to work, we got to sit in front of our computer for 7-8 hours at a time. Do the abdominal breathing. Have your water handy, drink your water, have a little coffee in the morning if you can. Do that 20-20-20 rule. But also, be aggressive and do prophylactic treatment. There are new drops out there that are they say on there for your screen time. So there's a lubricating drop that specifically says for screen time. I think it's by Alcon, but I'm not certain. But if it says for screen time, it's taking into account the fact that we're not blinking. And so it probably has again, those oils in there to try to kind of keep the tears from evaporating. I wear makeup, and thanks for showing the bugs that live on your lashes. How often should I change my mascara? Oh, the actual bottle of mascara. I hope you, because I'm assuming you don't mean on the eye. So on the eye every night, wash it off every single night with baby oil or an oil-based makeup remover. But the actual um, container of mascara, I think the longest we should wait is 60 days on those. I think we should be replacing those every 2 months on the mascara. That's a great question. And the other thing is I've seen people actually put in water inside their mascara. We call it topping off, to get some of the dried mascara in there. They're trying to make that mascara last a little longer. Don't be cheap. Don't do that. When you're putting tap water in there, you're having more bugs grow in that bottle of mascara. So don't do that. Could drooping eyelids affect dry eye disease? Is it a reason to have them surgically fixed? So droopy eyelids, you get more protection actually when you have droopy eyelids, because it's covering the whole, more than a sixth of the cornea, like we talked about before. It might be covering 30% or maybe 50%. So that is actually protective. But if they're non-functioning, if you stop losing some of the blink reflex, then that's an issue. Having them surgically fixed, I'm going to tell you, puts you at risk for more dry eye. So typically what an ocular plastic surgeon will do is we'll make sure that you have good tear production and that you have good tear quality, and we'll suggest treating your ocular surface before going into having surgery. And so that, because if you have a dry eye and now you have lid surgery and your lids are lifting up and you don't have good blinking or complete blinking, your eyes are going to feel worse. They're going to feel a lot worse. So a lot of doctors will prescribe lubricants or restasis therapy, like that cyclosporin I mentioned, prior to doing lid surgery. So lid surgery should be done on patients who obviously have maybe asymmetry. They don't like the way that looks, or if it's visually impairing you. And so a surgeon will have you have a visual field test where you look straight ahead and they shine lights. And if it's impairing your visual field, then that's a medical indication to have your droopy eyelids fixed. I would consider talking to your doctor. If it's not, I'll repeat that. If it's not visually, if it's not affecting your vision, maybe Upneek is an option for you in that method. And I'm also going to tell you that some people, again, who have bad dry eye, and we fit them in scleral contact lenses, those large diameter lenses, they actually, if that will lift the lid. So I have patients who sometimes I fit them only in one scleral lens for one reason or another, and where their lids were droopy, now I put that contact on and it looks bigger, and they're like, oh, I want both eyes done now. So that's another treatment for it. I hate fish, and I know that fish can help with dry eye. What should I be looking for in a supplement to help with dry eye? So that's a great question. There are a lot of supplements. Most of them have fish oil in them. That's those omega-3s, and don't give you that fishy taste, like that burpy fishy taste. So if you don't want to eat it, if you don't want to eat natural fish, there are a lot of good dry eye vitamins out there. And my favorite is I Promise. I Promise makes a whole host of things. And I will tell you, I'm on their medical board, so that's my conflict of interest there. But they make them for macular degeneration. They make them for computer vision, and they make them for dry eye. And that list of all those other ingredients that are helpful for dry eye that I mentioned before, primrose, vitamin A, vitamin D, those are all included in those too. So I have wet and AMD, which is 120 after 26 injections. Should I continue with injections? Oh God, don't ask me this. This is a retina question. And I don't know what Valida is. So the question is, I have wet AMD and has had 26 injections. Should I continue with injections? And will Lumathera valedictoria hold with other eye with dry and so this is a patient calling from overseas from Greece, and they don't know what's available in Greece. And I am sorry, I can't answer that question because it's a retinal question, and I'm not familiar with Veleda. So that would be another speaker. So sorry about that. I have breast cancer, and because of my chemo, I have lost a lot of the eyelashes. My eyes feel dry, itchy. What can I use to help my eyes? I would try. We have a lot of patients who have some side effects from their chemotherapy, and we need to be very conscientious. When I worked at University of Chicago, we did a lot of drug trials in the oncology department, and so we would watch for side effects of some of the agents, and unfortunately, dry eye was one of them. So again, tear supplementation would be really effective for you. You might be surprised that after you're done with treatment, your lashes will start to grow, just like as we lose hair on our scalp, we can lose them on our eyelashes, but they come back, and they come back even better. So I wish you the best with your treatment, and I hope that your eyelashes do grow back soon. But keep in mind, Latisse is a great topical solution that you can use that can help promote eyelash growth. Okay, and here I think is the last question. How can I tell the difference between dry eyes versus severe droopy eyelids? Ophthalmologist said eyes do not seem particularly dry, but gave me plugs. Anyways, allergy tests are negative and no other cause can be found. Ophthalmologist said my eyelids are clinically enough to qualify me to lift eyelid surgery, but I'm not in a hurry to rush into eyelid surgery. If I do have a lift, I have heard that at times it can cause dry eyes. And I think I answered that question. Yes, because if you do have lid surgery, some of the glands are affected. Sometimes it could be temporary. Sometimes they'll come back, but sometimes you end up with more exposure because your eyes are not lifted up high. Thank you for listening, and I hope this was helpful.
Well, it was not only helpful, I had no idea there were so many products made for the eye. Thank you very much. Our next speaker is representing a company that makes a product that can save your sight, literally. Megan Bledker is an ocular disease specialist, trained optometrist who practiced in Nashville, Tennessee for 9 years before transitioning to private industry. Now, she currently serves as Director of Clinical Affairs and Professional Relations for NotoVision. NotoVision is made for people with macular degeneration and is one of the most fantastic devices to detect early advanced macular degeneration into wet, and she's going to tell you all about that. I recommend her very highly, and it's now my pleasure to introduce to you Dr. Megan Bledker.
Thank you so much for the introduction. No-Tel Vision is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege. To reiterate some of the important points made in the presentation, I'd like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered. It's prescribed by your eye care professional when you have the appropriate level of vision and appropriate stage of age-related macular degeneration. It's a form of personalized medicine with the 4C Home device used at home in between your regular eye exams, and it detects metamorphopsia or visual distortions in AMD. AMD is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic, meaning it doesn't resolve or go away, progressive, meaning it tends to worsen over time, type of condition. And there are two types of AMD, dry and wet. Dry AMD is the slower changing, earlier form of the disease that puts you at risk for developing the wet form of AMD. And wet AMD is the sudden change or advanced form of the disease. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In dry AMD, changes occur in the cells of the macula, and drusen, or deposits, these yellow spots that you see here on the right side of the screen in the picture, build up in this area. And these changes may induce blurry vision, such as difficulty seeing sharp details both up close and far away. Dry AMD is the slow form of the disease, with changes you may not notice over time. Most importantly, dry AMD puts you at an increased risk of progressing to wet AMD. Over time, the size and number of these drusen or deposits can increase, which increases your risk of developing the more sight-threatening form, wet AMD. Again, dry AMD can suddenly change to wet AMD without any kind of advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula, as you'll see here on the right side of the screen. These blood vessels can leak fluid, and they can sometimes bleed without any type of warning. You may not notice these changes until significant vision loss has occurred. If you convert to wet AMD, this significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines look wavy. You can have dark spots in your vision, or just generalized blurry vision, as you see here on the screen. Unlike dry AMD, there are effective treatments for wet AMD, but these treatments are most effective when administered early on before symptoms are noticed and before vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but they cannot restore vision that's already been lost. Once the wet disease starts, it will continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and before symptoms are even noticed. But how early is early detection? Once symptoms of visual impairment are noticed, those wavy lines or dark spots appear in your vision, then the vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision, your independence, and the ability to go about your daily life participating in activities you enjoy. So, wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps people with dry AMD detect wet AMD before you even notice that visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision. The test takes just a few minutes per eye per day. The data from each test is then sent to your eye doctor as well as the No-Tal Vision Diagnostic Clinic, the medical provider of 4C Home. If a change in test scores is detected, the diagnostic clinic alerts your doctor. Your doctor's office will then contact you directly to schedule a follow-up visit. The Amsler grid, as you see here on the left side of the screen, was developed in the 1940s and has for a long time been recommended as a simple and accessible tool that you can use from home to monitor the changes in your vision. However, by the time you notice vision distortions on this Amsler grid, significant vision loss may have already occurred. Fortunately, new technology such as the 4C Home AMD monitoring program has been developed so you can detect tiny changes before symptoms are noticed, and the system reports them to your doctor so you can receive immediate examination and treatment if necessary. Testing with 4C Home is easy. You turn the device on and look into the viewfinder to begin testing. Then a bump will briefly appear and disappear, as you can see here in the center green circle on the screen. You'll use the mouse provided to click where the bump appeared and then return to this center dot. Data from each test is then sent to the No-Tal Vision Diagnostic Clinic for evaluation and provided to your eye doctor as well. Regular at-home monitoring is like brushing your teeth. It's just a good, healthy habit you do every day to help preserve your vision. 4C Home allows you to take a proactive approach to protect your vision. A clinical partner will be with you every step of the way. After the No-Tal Vision Diagnostic Clinic receives a referral from your doctor, we'll answer any questions, verify coverage, and ship your device. Once you receive the device, the No-Tal Vision Diagnostic Clinic will walk you through setup and training. You and your doctor will continue to receive feedback from the No-Tal Vision Diagnostic Clinic. Our team will be sure to verify your insurance benefits and discuss with you prior to your acceptance of the device and prior to getting started with the program. There are low out-of-pocket costs for Medicare patients. So patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan will pay $15.06 per month once their yearly Medicare fee-for-service Part B deductible is met. Again, 4C Home is FDA cleared and Medicare covered. Your doctor will send our No Television Diagnostic Clinic the order for you to begin the 4C Home AMD monitoring program. And appropriate candidates have a particular stage of dry AMD and a particular level of vision, which will be determined by your doctor. You'll continue to test regularly at home. If a change takes place, your doctor will be alerted and have you come in for an examination. In summary, the No Television Diagnostic Clinic works with your doctor to remotely monitor your dry AMD, helping you retain functional vision throughout your AMD journey. I'm happy to answer any questions you might have, and thank you so much. Here's my contact information for your reference. I would love to hear from you. Great, thank you for your attention. I'm going to pull up the Q&A section here, see if I can help answer some of these questions that have been posted. The first one is, I was just diagnosed with dry macular degeneration. My doctor didn't say anything about this program. Why? Well, I am so excited to be able to present this information to you today on behalf of the company. And I think you may not have heard about our program because we are a small private company. So we have just a few team members, although we are growing, and we are working to get the word out about our wonderful platform and the ways that we can be adding our technologies to your standard of care, to what you're doing as far as your follow-up with your eye care professional, and how we can support in detecting any changes in your vision between eye exams. So if you would like more information, you can go to our website, 4chome.com. We have a whole bunch of resources there available for you. I know on the MDA website, the Macular Degeneration Association website, there are plenty of resources as well, including our information. So if you could help us get the word out, that would be wonderful. Like I said, we are excited to be able to make a difference in your life and help protect your vision. Next question is, can you get this program any other way? So this program is only by your eye care professional's referral or order or prescription. And so the best thing to do is to, again, talk to your eye care professional first, make sure that you are at the appropriate stage of dry age-related macular degeneration and have the appropriate level of vision to be a good candidate for the test. And if you are eligible for the program, then that's when your doctor would send the referral form, the prescription form, to us. But it is by physician referral or physician prescription only. Next one says, thank you for presenting on this program. You're welcome. I use it and it actually caught my eye going from dry to wet. Outstanding. This is exactly why we do what we do. It's always nice to hear feedback like this. So thank you so much for sharing. And again, I'm proud that we could detect the conversion from dry to wet AMD for you earlier and hopefully make a big difference in your life and in your vision. So thanks for sharing. The next question is, I have arthritis in my hands. Can I still use this? So with our program, we make sure that our team, which is a group of technicians, ophthalmic technicians who've often worked in retina practices before, they would go over how to use the device with you and what that all involves before we would send you the device, before you agree to use the program and move forward. And then after you receive the device, if you'd like to move forward with the program, that same group of individuals will call you back and they'll walk you through exactly how to use it. And as you may have seen in the pictures during my presentation, there's the device itself, and then there is a mouse that you'll use your index finger on your right hand to click where you saw the those bumps or those waves in the lines. And so if you find that because of arthritis or a tremor or for any other reason that after you receive the 4C home and you're using it and you're not able to continue doing it, if it's too difficult for you, we will absolutely take the device back. We'll take care of all the shipping back and forth. So there's no obligation. Again, we want this to be an adjunct to what you and your doctor are already doing to monitor your AMD and to help preserve your vision. Next one says, I have some vision loss. Will this machine pick up the changes should my eyes convert? So the 4C home device and the way the artificial intelligence or the way the system analyzes all the information that's collected every single time you test, it will compare where you started, what we call your baseline, to where you are currently. And if it notices that there's something statistically significant that's different, if they notice there's a change, this is not what they're used to seeing as far as your responses, then it will actually send that alert to us and we'll send to your physician to bring you in for examination. Now, an important thing to remember is that this 4C home technology is essentially a metamorphopsia or a vision distortion detector. So there will be some changes in your eyes that can take place. Age-related macular degeneration is a very dynamic disease. It's a chronic, meaning you have it long-term and it progresses or it changes, it can advance. And so because the technology is so sensitive, it will sometimes pick up on those changes. So occasionally you would go in for an examination. They may find that something has shifted with your age-related macular degeneration, or because it is assessing a very important part of the retina, that macula right in the center of your eyes, there are other diseases that can cause changes or metamorphopsia in that area, which would be detected by 4C home and would trigger that alert. So it's best that if you have an alert with the device that you'll go in and see your doctor and determine what's going on and determine any next best steps. So. And I think that's all the questions I see there. Wasn't sure if you had any questions, Larry, or anything that you wanted to add. Thank you so much for your kind words at the beginning. And Notal Vision, I am so privileged that we get to partner with you and the Macular Degeneration Association. And it's just such a privilege. And I'm so glad that we can work together to share information and provide education and be able to help more people.